and see. We ask ourselves the same old question: who will be there for me?
Welcome to the first show of Healthcare Update. I'm Richard Davis, and this guy here is Daryl Pillsbury. And
Hey.
You might know us and you might not, but by the time we're finished, you'll know us a lot better. So what are we up to? Okay, here's the plan. Once a month, Daryl and I are going to sit down, pick out one or maybe a few healthcare-related stories or issues, and we're going to try to talk about them enough so that they actually make sense to people. Like get into some of the details and have a discussion and throw it back and forth between us and see if it sheds a little bit of light on the subject. So that's the idea. And I'm going to introduce myself with a little background, and maybe we won't have to do that after the first show, and then I'll let Daryl tell you who he is if you don't know already. So I'm Richard Davis. I'm the Executive Director of the Vermont Citizens Campaign for Health. We're a single-payer advocacy organization. I've been a nurse in Vermont for about 32, 33 years, something like that. I write a weekly column in The Reformer. I've been writing it since 1994 on healthcare issues. And so, you know, I'm a healthcare activist and concerned about healthcare issues. So, Daryl, tell people who you are. What's the deal?
All right. Well, I'm glad to be here with you, Richard. I'm not really sure what we're going to be doing on this show either, but we are going to try and get you to understand healthcare and the problems associated a little better. I'm Daryl Pillsbury. I am on the Brattleboro Select Board currently. I served 8 years as a state representative for Brattleboro's District 2, and I'm involved in all sorts of different things around town. And when Richard called and said, let's do a healthcare show, I thought it was a good idea so that we could start educating and getting some more facts out there for folks to understand. One of the questions I'd like to start off with, though, Richard, is, if it's all right.
I don't know. We'll find out.
Yeah, is you know, you and me. This is what got me in politics. Actually, was healthcare issue, and I was for a single payer, which you know how that word can be. But for me, I'm hoping this show will try and break the divide that we have, because you know, as soon as we say single payer or anything like that, Richard, people start digging in, and then we don't really go anywhere.
Right.
And for me, it's like I just can't understand why not. So maybe you can start talking a little bit about what it is your group does, the new legislation that's coming out. Maybe we should focus with that this week.
Right. Well, Daryl, you're absolutely right. I think that activists have done a poor job of bringing everybody into the fold. You know, we generally preach to the choir, and it's always the same old usual suspects that show up at these things or listen to us. And it would be much better if we got a bigger, broader audience to listen to what we have to say.
So now we're trying to make it so they can just sit at home,
Right.
relax,
Make it
and they
easy.
can even throw stuff at the TV if they
Right.
don't like what we're saying.
And it doesn't come through to us.
That's right.
I guess that we
We're
haven't got that
filtered.
technology yet. So, well, okay. So before we get to the topic that I wanted to talk about today, we'll backtrack a tiny bit and say we're not out to push one agenda on anybody. We really, truly want to inform people. So we won't talk about single payer unless it comes up, which it will, and then we'll talk about it. But we're really not pushing any particular agenda here. We really want to get as many people involved in this issue as we can. So that's why I think today we're going to talk about one very specific issue. Okay, so during the last legislative session, as Daryl well knows, although he wasn't there, but he kept track of things pretty well. And also, I want to make it clear that since Daryl was a legislator, he has a lot of inside experience about how this process works, and I don't have that kind of experience. So
Yeah.
I'm going to, maybe. So, and I'm going to count on him to say, no, the reality check is, no, this is how it'll probably happen, or if you do this, this is what. So, you know, Daryl has that experience. So, all right, here's the story for what we're up to today. Okay, last session, a bill, they didn't do a lot with healthcare reform in the Vermont legislature, but they did pass a bill that calls for the design and implementation of a plan for reforming healthcare. And that plan has to include 3 models. One model is a single payer, one's a public option, and one is a model as yet to be determined, and will probably be determined by a meeting with the people that were hired to do the study and the legislative leaders. So, okay. So
Well, that's part of the study, right, in its own, part of the bill in its own right is to get some outside consultants,
Right.
1 or 2,
Right.
to come up with this plan. The number C, the third, and any additional options. And they are to talk about the publicly financed single payer or self-insured.
Right.
And then the other one would be administered by state government or federal government.
Well, it
So
could be anything.
that's right.
It could be saying, all right, we have such a wonderful system, we'll keep it the way it is.
My thing when I was reading this though is they want it done fairly soon.
Right. Okay, so here's the timeline. Well, let's get into some of the details. First of all, the Healthcare Reform Commission recommended who to hire, and then the Joint Fiscal Committee actually hired the person. So the person they hired, his name is Dr. William Chow. It's HSIAO. He's an economist from Harvard, probably one of the most prominent healthcare policy people in the world, not just the country, in the world. He designed a number of healthcare systems around the world, most prominently in Taiwan. Taiwan instituted a single payer system in a matter of a couple of years. They went from having a mess like we have, or maybe worse, to a pure single payer system that's actually very successful. He's consulting with China. He's working on a plan there. He's quite an amazing guy in terms of his credentials, but he's also, and I've heard him talk, and the Vermont legislature invited him last winter to talk about some of these issues. He's very engaging, but he has the ability to take a very complex issue and make people and allow people to understand it, which is pretty remarkable. Now, the other thing about Chow is that he's not doing this study alone. He's recruited another guy, Jonathan Gruber, who's another economist from MIT, who's way up there in the stratosphere too in terms of policy. And then they grabbed this guy, Steve Capel, who used to work for the Joint Fiscal Office. He's basically a numbers cruncher, and they wanted a Vermont connection. So this trio are going to be doing the study. The study has to be, the first draft of the study has to be presented to the legislature January 1st, 2011. That's like, let's see, this is end of July, so we're talking August is September, October, November, December, January. All right, Joe's telling us 6 months. All right.
He's pretty good at math.
Good at math. He has more fingers. All right, so we're looking at 6 months to design all this, which is not a long time. And then, and this is probably one of the more important elements of the whole thing, is that the legislature has to provide 15 days for public review and comment on the options. This is where the people come in.
That's
Okay?
right, and that's when we need the people to come in.
Right, and so part of what my organization, the Vermont Citizens Campaign for Health, is doing and is planning to do between now and January is to educate people better about what all these things mean and what the options mean, so that when the time comes for public comment, people won't be having to react to something they don't understand. Hopefully by then people will be up to speed and they'll be able to react. So now, Daryl, based on your experience, how do you've seen some of these public comment kind of things. So do you think this is going to be different? Is it, we'd really like not to have the usual suspects show up, but that'll probably happen. I mean, how do you think we can make this so that we get a broader cross section? I mean, that's the hard part.
Well, a couple of things and one of them we've already started to do as far as, and like you said, it is going to come up, the single payer plan. That's one that a lot of us tend to resonate to. People. We need a lot of people to come up there, and we need to change what we're calling it. Single payer scares everybody, but when you say self-insured, I work for Brattleboro Memorial Hospital. As you know, it's a self-insured business. People understand what they're talking about there, and that's all we're talking about here for the state. Now, the other part I'd like to say, since we're talking about studies, is one of the things as a representative, when I first went up there, this study's costing us around $300,000, okay? It's a lot of money.
Yeah.
And hopefully we get a good bang for the buck. But these studies are very important because we have a citizens legislature. These are people from all walks of life. I mean, even the folks up there haven't spent as much time as you have on this issue. So, they need the studies from people who are nonpartisan, who can come in and give them the facts and not have any bias. So I think that this was a good start for a bill and a good way to hopefully get both sides together to find out how we can come out with something everybody at least can agree upon. Because the way we're going right now, Richard, is just nuts. The amount of money spent is incredible in healthcare. Of course, then again, we go to a lot of the people that oppose the way I feel about healthcare. It's fundamentally the way we feel. I mean, I feel that healthcare shouldn't be a profit-driven entity.
So that gets us to the real big question: is the political process, lobbying, campaign finance reform,
which is huge
so
there.
tell us, I'm sure you have a few
Well,
ideas.
you're going to have every pharmaceutical company is going to come in and spend a ton of money to get, and I'm sure there'll be a few lunches done with these guys.
Big lunches.
Okay.
Big lunches.
Private ones and stuff, so that they can have their say, and that's why it's important for the folks when you do have a public input. Or a public hearing, whether it's at the State House or they, tend to sometimes move around to different areas of the state, to go and have your say, even if you've said it 20 times before, because there's new people always in there. And when we have them in the well of the House, the bigger ones, and we have public hearings, you'll see a lot of representatives and senators that aren't on these committees of jurisdiction sitting out in the peripheral areas listening. I mean, I used to go to quite a few of them that I wasn't on my committee, but I was interested in the topic.
Do you think it might be worth it for the Healthcare Commission that's soliciting the public input to do a roadshow instead of allowing that 15 days to pass with maybe one hearing in Montpelier? They should go around the state.
I would hope they would do that.
Well,
even though I
don't
know 15 days is tough, but
Yeah.
you could have 3 or 4 around the state. You'd want one, have one in Montpelier, have one in the southern end, the northern end.
Well, it's not like they don't know about it 6 months in advance, so
Yeah.
if they could plan it.
It would be really nice
Well,
if we
I'm
could,
gonna
and we
write
could
that
definitely
down.
have
That's a
one.
good idea.
And have them in the different counties where we do tend to disagree more. I know the Northeast Kingdom is far different than we
Rutland,
are down
too.
here.
Yeah, in Rutland
okay,
County.
Rutland is a little different than we are down here, or even Burlington. So I think it's smart to go around through different areas of the state so that everybody has an opportunity at least to get there.
Right.
That would be, one of the suggestions that I'd have to them.
And, let's talk about a little bit about some of the details, because people say, oh my God, it's another study. Haven't we studied this to death?
But this is a study that's going to come with a plan, I think,
right.
right?
Well, here's the thing. No other study, I don't believe, has said this. Here's the language, and this is very interesting. It says that each design option shall include sufficient detail to allow the governor and the General Assembly to consider the adoption of one design during the 2011 legislative session. And here's where it gets interesting, to initiate implementation of the new system through a phased-in process beginning no later than July 1st, 2012.
Right.
That's tremendous. However, as history has shown us, Massachusetts, other states have passed similar legislation and then it just dies because it doesn't get funded.
That's right.
So,
well, we're having that problem somewhat on our Catamount Health area.
yeah.
too.
But just because a bill passes doesn't mean that it happens.
That's right.
And Daryl can attest to that, I'm sure. It's like everybody thinks, oh, you passed a law, it's going to happen. Well, no. It doesn't happen.
Sometimes sometimes the bureaucrats can take over and mess with them.
Oh, I can't imagine that.
Yeah,
How
it
could that
happens.
possibly happen?
It happens.
All right, so maybe it's not another study because it's actually requiring something to be done. The other part of this, which I think is really important and it's kind of interesting, is that the consultants, Dr. Chow and his cohorts, they're going to have to take into consideration the federal bill that passed last March and actually look at the implications of that bill for Vermont in terms of this recommendation.
And that's one of the reasons why, Richard, I think it's good to have these folks who are highly qualified to do this. Because, like I said earlier, I'm a maintenance man at a hospital. These are quite extensive bills. We need people that, as a legislator when I was up there that I could have access to these folks and ask them the questions that I needed that maybe constituents asked me, things like that. So it's very important that we have people that actually can see us through the whole process and say, okay, that are non-biased.
Right.
Okay, that'll say, hey, listen, this isn't a way, maybe my idea doesn't work. Maybe it just won't work.
Right.
Okay, but maybe there's another way of, implementing what it is that we would like to see happen so that everybody is insured and we don't have as much cost shifting as we have now, because that's another big thing that I'm sure these folks will be talking about in this is the amount of cost shifting.
Yeah.
Just for example, and I just want to throw
you
this
know
out
what?
there.
Let's define cost shifting, because everybody everybody throws that term around.
Go ahead.
all the
That's a
time.
good one.
Okay, I'm going to give you the definition. It's shifting costs. No. Okay. So,
Yeah, there you go. From one person to another.
basically, that's it. But here's how it happens in healthcare. Okay, you go into the emergency room and you don't have insurance. Okay, and you run up a bill of $10,000 while you're there in the hospital. Okay, you don't have insurance. The hospital eats the bill. Okay, what happens next? The next guy that comes in has insurance, or here's where it gets you more interesting, or doesn't have insurance. I'll tell you those two possibilities. So the one with insurance, how are they going to recover that money? Well, then you have to step back. Every hospital negotiates with insurance companies for different rates. If they have had to give away a whole bunch of free care the year before, they're going to try to negotiate higher rates to make up for the money they lost on the uninsured people. So that's cost shifting. Cost shifting is when the hospital buys an aspirin for half a penny, and then on your bill it costs $3 for an aspirin. That's another way to cost shift. They're allowed to mark up, I think it's 300% or maybe more now, but they can mark up any supplies 300%, and so they can recover costs from people they lost it from people that can pay. The other way they cost shift is unfortunately, most hospitals charge people without insurance more than they charge for insurance companies for people that are insured. So everybody pays a different rate when they get health care, which is really obscene.
Yeah,
and
it's
so
ridiculous.
that's cost shifting, because the cost keeps getting shifted around to everybody else. All right, so.
Well, and my little thing was going to be, I was just going to take me for an example. I pay $400 a month out of my pocket for my health care insurance. Hospital pays about $9. It's about $1,300 a month.
That's a lot of money.
For me and my family. I'm on a family plan. Now, and when I look at bills, and then I got co-pays, and I got deductibles, and I got deductibles for equipment. The family has to hit $350 deductibles. I mean, all these deductibles and stuff. So I'm actually paying more than the $4,800 out of my pocket per year anyhow.
For what?
And here we go again, and I didn't want to try and do this, but for a plan that I would like to see, like a self-insured plan, where you say, when people ask us how you're going to pay for it, we say there's going to be a tax. Oh my God, all of a sudden everybody freaks out. Well, I'm already being taxed.
Right.
That $400.
Well, imagine having a tax and then no premiums.
That's right. Okay, I would come out ahead if you decided to take 4% out for a healthcare tax. And I don't know if that's what it would be, but for me, it would be less money than what I'm paying now on healthcare. So everybody would have a healthcare tax. But now, it's something I would like to see. But what we're talking about today, folks, is this plan. And that will be one of the things I think that will be on the table amongst others, which Richard has talked about.
They'll have to talk about financing, So will it be payroll tax? Will it be an income tax? How are they going to pay for it?
And we also got to get over that thing where people don't believe, the fundamental right is, I feel it is a right for the government to provide health care. There's a whole bunch of other people out there that don't.
Right. And
that's a discussion. And that's huge, trying to just get over that hurdle.
Well, that's a valid discussion, and unfortunately, we're the only country in the world that's never had a broad, nationwide public discussion about what we think about healthcare. Canada has had numerous discussions, and then they keep reinventing the healthcare system, but this country has we've never decided or never had the discussion that says, do you think healthcare should be a right of citizenship, or is it a privilege based on how much money you have?
And right now, it's privilege.
Right.
It's
now,
the privileged.
you get the best healthcare if you can afford it. But if you can't afford it, you don't get it.
We have so many people that aren't. I don't know. Man.
All right, so let's get back to cost, because this is interesting. I think it's worth describing the language in the bill, because it's hard not to get people to agree that everybody should have a basic set of benefits. But then when you get down to the financing, that's really what divides people a lot. Not always,
Yeah.
but that's really, especially this is where the legislative part falls apart, because when it gets to the legislature, as Daryl well knows, it's all about the money.
It's all about the money.
And if you can't figure out how to pay for it, you're not going to have a bill that gets anywhere. So here's what the study says. It says that the plan has to talk about financing and estimated costs, including federal financing. And what does federal financing mean? That means waivers. And I don't want to get into that now, but really what we're talking about is if you want to have a very comprehensive system, then we need to be able to pull all the money from Medicare, Medicaid, all the federal programs into one big kitty. And that's a whole nother issue that may or may not happen in 2017 because Bernie Sanders stuck this into the health care bill that passed last year. So anyway, that's one of the issues. But then the consultant has to give an estimate of the total cost of each design option. Now that's really important. And they have to include any additional costs for providing access to and coverage for health services to the uninsured and underinsured, and any estimated costs necessary to build a new system. So really, they have to have a very comprehensive picture of the financing.
And I think that is key to this whole thing, because that's when you can get the other side, if that's what you want to say, to come together. Because if you can show 2 models or 3 models and show one is far better than the other one, then I think you will get people on board. Because even the folks that disagree with me realize that we are not running a sustainable healthcare system, which I don't even call it a system, but even they know that. So that's the one thing we agree on. Even the people that disagree with the way I feel about healthcare understand that we cannot keep doing the costs the way we are. So I think that is the key to this whole bill, and having these qualified folks that we have doing it adds a lot of clout. Because if you and me tell them, it doesn't matter.
Well, I think their numbers will be credible.
I do too.
They should be considered a neutral source. They have nothing to gain except $300,000. But it doesn't matter what they say. Whatever they recommend, it's no skin off them, because they're not going to be building. They're not going to
implement it.
Yeah,
they're just the ones coming to.
They're just making recommendations, so
right.
they have nothing to gain by what they say. And here's the other issue in terms of financing, that the language in the report says that whatever the financing proposal has to have a sustainable revenue.
Yeah,
so
that's
this is
key.
really interesting. And from Daryl's point of view as a legislator, we know how important that is. It's like, okay, you might have a bill that calls for, like $500 million to implement a system, but how are you going to sustain it? And most legislators won't. They would call it irresponsible politics if they passed a bill that didn't have any sustainability built
Although
into
that
it.
does happen, but that is very true.
And
they do look for that, and it is a selling point, because a lot of times if you're going to start a new program or try to fix a program that's not working the way it should be, that is a big key element.
Right, and then what they say further on in the language is, so how would they, create a sustainable revenue? First of all, by maximizing federal revenue. So that's what I get back to with these waivers is possibly pooling money, but also every state gets a lot of money from the federal government for health care. So
Which people don't realize that, Richard.
Right.
What's the percentage already? It's in the 70s, isn't it, from the feds and the state?
Well, I don't know about the feds, but overall, our health care expenditures are paid for by 60% of the expenditures are paid for by tax money, federal and state.
Yeah.
So that we already do that. So, but we could maximize some of the money we get, especially the Medicaid money, and then the consultant also has to look at reductions from the existing healthcare programs. In other words, trimming some of them possibly. That's reasonable. Looking at services, state agencies, or other sources necessary for funding the cost of the system. So this has to be a very well thought out funding mechanism. This consultant can't just say, all right, the system's going to cost $500 billion. Here's the plan. No, the consultant has to say, this is what it's going to cost, and this is how you're going to pay for it, and this is what it's going to mean
Right.
at every level in society. And that is tremendous. Nobody's ever done a study. So, and I have to tell you one thing.
I hope they can get it done in 6 months.
Well, I think if anybody can pull it off, it's this guy. And the interesting thing, we're getting close to the end of the show here, but the interesting thing, Daryl, is that I regularly talk to other activists around the country that do what I do in different states. Everybody knows about this study, and they're waiting. They're waiting because they want people in New York and Kentucky and Oregon and New Mexico and Ohio, all these states, they're looking at this, and this is going to be their template. Of course, a lot of single-payer people think that single-payer is going to shine in this study. I may, that may be a bias.
It may not.
May not.
We're going to find out.
We're going to find out, but, whatever the consultants come up with, it's going to be very, very important information. So that's why this study is critical. It's critical for the state of Vermont, but it's also going to, once again, as we've always been, we've led the way for the country to move in the direction of a more
Insurance for all.
sensible, sustainable healthcare system that covers everybody at a cost we can afford.
That's not profit driven.
Right.
Hopefully.
So we've sort of just got into scratch the surface on this bill, but I hope, and Daryl, if you want to add anything, get another minute or two, but I think that we've at least given people a sense of what the bill's about. Now, we've been looking at the 7-page thing that I've extracted. This is available, and it'll be at the end of this show. You'll be able to see the website, but it's on our, so you won't have to go searching for it. It's at the Vermont Citizens Campaign for website. It's Campaign for Health website. It's www.universalhealthvt.org, and you'll see it right after we finish talking.
Easy to get to it.
So is there anything else, Daryl, that you think we left out that we needed to
Well,
say?
Richard, a half-hour show on healthcare, are you kidding me? We're going to be doing these monthly. We'll keep trying to keep folks aware of what's going on. No, I think that this is what we need to do. We got to start getting out there and informing the public any way we can, and take feedback.
Right.
You can get a hold of Richard or myself and give us some feedback on what you think. And hopefully we're going to do this every month.
Yeah.
And,
if we need another voice here, we'll try to grab them in. But,
But right now
we'll
it's
see.
going to be pretty much our vision.
Right. Right.
And we'll try and inform people as we go, because I've given up the arguing so much now with the folks because it's just I'm just burnt out of arguing. Now it's time to do something.
Right.
I just don't understand why people want to continue down this path of no return.
Well, that's what we're doing. Daryl and I are just trying to do education. We're not trying to push any viewpoint. So
Right.
talk to us, stay informed, and we'll see you in about a month.